Good morning, ladies and gentlemen. This is Aisha Shehi from the National Insurance Company Laman, and I am part of the disease management team. Thank you for joining us today in our diabetes webinar session. November is National Diabetes Awareness Month, a time to raise awareness about diabetes and the impact that it has on millions of people worldwide. Please join me in welcoming our speaker today for today's session, Dr. Tomader Ali from the Imperial College London Diabetes Centre. With over 20 years of experience in research and academia across the UK, Europe, USA, and the UAE, Dr. Tomader has an extensive expertise in the field of diabetes. Please note that you can send your questions through the Q&A chat box anytime during the session, and we will allocate 15 minutes at the end to answer your questions. Dr. Tomader, welcome. The floor is yours.
Good morning, Aisha. Good morning, Tanis, and all the Zaman team. Thank you for the kind invite, and of course, all the attendees for their time with us today. As you quite rightly mentioned, this month is International Diabetes Awareness Month, and tomorrow is International Diabetes Day. So thanks for the great awareness session, and I hope together we will spend, a helpful and bidirectionally useful time. If you'd allow me to share my screen. Okay, good. All right. All right. Okay, so for today, we'll talk about diabetes really in 2026 and beyond. So we're already having a future perspective on what we actually know and what is new, whether in terms of therapies or innovation. So today we'll talk about diabetes as a condition and disease state. How do we achieve good glycemic control, and some misunderstandings and misconceptions, factors affecting blood glucose level and control, and therapies, old and new, as well as what's new in lifestyle modification and holistic well-being, because that's an integral part of a quality of life, and also technology and innovation. We can't, talk about anything today without technology and innovation, and diabetes is no different. So let's talk about diabetes as a condition and disease state. Is it simple or is it complex? And I'll let you be the judge of that, but I have some things to share. So initially, what you're looking at here is our pancreas. And if you cross-cut or cross-section a pancreas, it looks a little bit like this. So if you look inside it, you're actually able to see, this is part of your digestive system, this is your spleen, and there are lots of blood vessels coming in to make sure everything is healthy and has all the nutrients it needs. And if you look inside, you see these blue dots. I mean, they're not blue in real life, but just to make you be able to see them. They're called pancreatic islets. And they're a group. If you look at them under a microscope, they look like this. And if you see these multiple dots inside, they have different cells, alpha, beta, and other exocrine acinas, but it's the pancreatic beta cells that we're interested in, because these are the ones that give us insulin. So any person with diabetes, regardless of what type of diabetes, would have an issue with the pancreatic beta cells. Either they're not secreting enough insulin and you have insulin resistance, like you have in type 2 diabetes that comes often with lifestyle and obesity, and we'll talk about that, or type 1 diabetes, where these cells are completely destroyed due to an autoimmune attack on the body. So again, diabetes is, we're focusing on the pancreas. And again, if you look inside, these are your dotted pancreatic beta cells. So if it's just about insulin, surely it's very simple. It's just one hormone that we are talking about. Well, actually, insulin itself is a mixture of things. Initially, it looks like this, and we call it proinsulin. And it actually has these bonds have to break so that you see this red chain of amino acids connecting peptides, and this yellow chain have to separate. Only then can insulin be active in our body, which means that it can understand that there is a high blood glucose after we ate a cake or a donut, or we forgot to take our medication, which we will talk about. then the insulin has to come out from inside those dot cells to come out and rescue the blood glucose, make it go down and become normal. So it takes some time to do that, okay? So we have insulin that is happening, it's there in the background, and this is, to maintain this background level of glycemia that we say. And if we eat something, it quickly comes out, and it's called a spike or a biphasic action, so that we can make sure that this donut or this chocolate that we ate does not give us too much high blood glucose. So it really is very specific and very cool, if I may say so. And it is complex because inside there are all of these letters are proteins that make sure that the insulin and other things in the cell are doing what they need to do. And of course, our biology has DNA, has genes, and these genes also affect how the insulin works. And why are we talking about this insulin and diabetes? Because in the UAE, our statistics of diabetes and obesity and related topics for diabetes, whether type 1 or type 2, are really high. And this is, as quoted correctly here, it's a silent pandemic. We have, children, adolescents that require our care. We have people who are at universities and colleges. We have people who are older senior citizens. We have people with complications. But you ask, is it only us? Absolutely no. This is global, and we know that across the world, there are thousands and thousands and millions of people with diabetes. And the numbers, so if we look at 2021, the world population, 7.9 billion people, right? And of them that have type only diabetes between 20 to 79 years, 536 million people. So is it getting better? No. 2030, we will have more people in the world that have it. And 2045, even more people. So this is affecting millions of people. And awareness is very important. Mindfulness is very important. Understanding why it happens is very important. And what can we do to prevent it earlier as much as possible is really important. So this is a public health issue. There is a disease burden, and there's health economics as well. When you think about our health and insurance and our lifestyle, all of these things are connected. So then if we want to be good at this, and we want to reduce blood glucose, and we want to be healthy and not get diabetes, or if we have diabetes and we want to make sure we are maintaining our blood glucose levels, what is it that we really should do? Well, one of the things that we should address is misunderstandings and misconceptions. And you would not believe the amount of misconceptions there are, but I will share just a few here with you today. Diet alone can control blood sugar or blood glucose. But this is not quite true. It is a big part, a significant part of having a healthy lifestyle. And that is a big factor. But it is not the only factor. And it also depends what type of diet. So some people think, I just reduce my calories. Okay, well, you can eat chocolate for 100 calories, or you could eat salad for 100 calories. Same calories, different quality of food. So it's not diet as in reduced calories, diet as in choice of healthy food. Okay, so, it's really important to think of that first. The second thing, this diet, just by itself? No, because I need to think about if I am on medication or not, if I have a desk job, or I have a job where I am out and very physical and I need more calories, healthy calories, and I have to monitor my blood glucose or blood sugar to see if what I am doing naturally, of course, under the supervision of healthcare professionals, is it actually working or not? Am I getting the results I need or not? What can I do to improve or maintain if I get this really good blood glucose control? So carbohydrate, the composition is important, but also timing. And we'll talk about timing, because I could eat nothing during the day my metabolism goes down and it's very slow. And then I eat in the evening and everything goes up, the sugar, the hormones, and my body thinks I'm in starvation mode. It does not know when I'm going to eat again and starts to store this food as fat. So even if you eat one meal and it's at the end of the night and it has high calories and you don't move or exercise, you are still probably going to gain weight. It depends on a few other factors, but likely. So, diet alone can control blood sugar is not exactly accurate. The next thing is, are all carbohydrates bad? I mean, this applies to even fats. You hear about good fats and bad fats, good carbohydrates and bad carbohydrates. The idea is it's a mixture of quality and quantity. So we want whole grains, rich fibers, and again, bearing in mind the calories. And why? Because if you eat something that has a simple sugar, let's say a sweetener, okay, or a sweet, then it's simple sugar. The body does not need to break it down. Your blood glucose goes up very quickly. Your insulin has to come out very quickly to help bring it down. Your body is rushing. You need the body to very stably, continuously throughout the day, eat healthy, whole grain, fiber-rich carbs, healthy fats, so you can maintain. It's important to not go up and then go down and up and go down. It's good for the body to keep it maintained. Now, we talked about different types of diabetes, let's say type 1 and type 2, and eventually all patients end up on insulin injections. Now, insulin therapy, a lot of people feel that it is a sign of personal failure, or that the disease is getting worse, or that, I cannot reduce my complications anymore. While there is truth in all of this, that, because in therapy we have first line, second line, first, for example, in type 2 diabetes, diet and exercise. If not, for 6 months monitored. If not, we have oral medication, so pills and tablets, and we will talk about that. And if not, we go to insulin. So yes, it's a progression, and we have to maintain as best as we can to avoid that. But just because we go on insulin doesn't mean it is failure. For type 1 diabetes, it's slightly different because, like we said earlier, those pancreatic beta cells, there's an autoimmune attack and they are completely obliterated, which means we don't have any intrinsic insulin that the body secretes itself, and we have to inject insulin. So it's nobody's fault, right? It just happens. That's how the biology is, or the pathobiology of the disease and our biology. And so insulin therapy is not a sign of failure, but it is a way that requires a different mindset when we are managing our insulin therapy. And a lot of people with both type 1 and type 2 who are on MDIs or multiple daily injections of insulin live a full life with all their activities. I mean, in fact, you hear every now and again stories of celebrities, sports icons, global, who have type 1, and you can see that they live a very full and happy life. Another one is symptoms are a reliable indicator of blood sugar levels. Many people believe they can feel when their blood sugar is high or low, and not always the case, okay? And we have, for example, something called hypoglycemia unawareness. So hypoglycemia is when your blood glucose drops below the target or recommended normal range. So maybe you took your injections or medication, but did not eat enough to match what the medication dose you took, or you ate and you took your medication, but you went for a really intense exercise session. And so, or you didn't eat for a long time. So sometimes the blood glucose, would go down, not just too low, but very low. And that's dangerous because the person can lose consciousness. Imagine if they are driving or they are operating heavy machinery, that's a danger to themselves and others. And so, but what happens is in hypoglycemia unawareness is the person over time, if this happens a lot, they don't realize anymore that their blood glucose has went that low, which means that symptoms are not there anymore. So symptoms are a reliable indicator of blood sugar levels? No, not always. So I think with this, we will talk later about how technology is going to help us monitor our blood glucose. And if we don't, we can also do SMBG, self-monitoring blood glucose. But it's important to understand that not always the symptoms are reliable. Okay, so we talked about diabetes, different types, biology, the physiology, the misconceptions. Now, what else can affect this blood glucose and how can we control it? Because, you know, one of the problems that with diabetes, it's like we said earlier, it's a silent pandemic, but it's also a very silent disease. People can have it for a long time, not realize, and when they have it, not always have severe symptoms. And so a long time can pass before people start having problems with their eyes, retinopathy, with their fingers or toes, the extremities, neuropathy, nephropathy with their kidneys, and oral issues with gums and teeth, and so many other factors. So it's really important to understand this way in advance in the process. And I don't expect you to see all of this in details, but just to give you an idea that the factors are multiple and they all talk to each other, you know? So we talked about diet, we know a lot about physical activity. It's not just how long you exercise, but what type of exercise. If I run for 20 minutes, it's very different to me carrying weights for 20 minutes and doing resistance exercise. We talked about medication, but also stress and mental health well-being and the psychology, illnesses and infection. You know, we know that patients with diabetes, if they cut themselves, it will take a little bit longer to heal, and the other way around. If they have poor metabolism or insulin resistance, this can cause diabetes. So it's a bi-directional relationship with all of these. Other health, you know, style and lifestyle include alcohol consumption, recreative drugs, and smoking for sure, hormonal changes in females, particularly during menstrual cycles, pregnancy, or menopause, weight and obesity, and this is age independent, whether you're young, middle-aged, or older. Hydration is really important because if you think about it, if you have let's say one effervescent, you know, the vitamin C tablets, the effervescent in the water. Let's say you have it in a small espresso mug. It's too much, right, for the volume. Now imagine you put it in 1 liter bottle. Yeah, it's the same effervescent tablet, but having the volume of water changes the concentration of the vitamin C. And so here it's the same. If you have 100 milligrams per deciliter blood glucose in 100 liters or 1,000 liters, it's a big difference, the dilution. And so dehydration is really a problem, and it can give you an increased blood glucose and impair your insulin action. So hydration is very important. When we talk about circadian rhythm, this is our day and night cycle. And you know, this is linked to sleep, and this is linked to stress, and this is linked to how the body works, the muscles, the fat tissue, and the insulin. And we'll see this in the next slides. So all of the things are really connected. And some hormones peak at night, early morning. So having disrupted sleep affects our circadian rhythm and impairs our insulin sensitivity and therefore our glucose disposal. And if we think about it, when we think about culturally how this affects us, you know, we published a review about chrononutrition in Ramadan. And why is that important? Because in Ramadan, our day really flips, right? So if this is a little bit complicated, but the general idea is we have a night cycle and we have a day cycle. And you can see this hormone acts here, insulin acts here, this other hormone for adiponectin for the fat tissue works here. This is for satiety and how hungry you feel, it works here. So when we change the day and night, it's really going to affect when the hormones come. How does this affect our satiety, our feeling of hunger? If we are taking medication, we have to take care of that. If we are injecting insulin, we have to think about that. So Ramadan education, Ramadan, before Ramadan, is really important. So if they have diabetes, or you know somebody in your family or friends who has diabetes and intends to fast Ramadan, it's really important they speak to their treating consultant and physician and seek diabetes education from the healthcare team and dietitian team also, to make sure they are prepared for safe fasting. Okay. The other thing that we think about is temperature and insulin absorption. Why do we need to think about temperature? Well, because heat accelerates insulin absorption and cold slows it down. So, you know, people in different environments, in different countries, even how to store insulin. We know that insulin has to be stored in the fridge, not to be frozen, not to be in the heat, direct heat for too long. So this is really important, because if we take a drug like insulin, a medication that's supposed to help us, but it's ruined because we froze it or we put it in the car and we forgot about it, and it's the summer and it's 50 degrees, then that's an issue. Also, our internal body temperature. So if there's some illness and the temperature, internal temperature increases, low-grade fever, medium-grade fever, high-grade fever, all of this will affect, insulin. And so we have to monitor our blood glucose very well. And you know, when we talk about shift change of day and night, we talk about Ramadan, we also talk about, think of the people who are, for example, fasting in Sweden, okay? When they have sometimes a few hours of daylight. Can they fast all of these hours? No. People who work shifts, let's say I'm working a night shift, then what happens to everything, in my circadian rhythm? So my hormonal secretion is changed, insulin sensitivity is changed, my glucose metabolism is changed, because I'm eating now also at different times, not just sleeping and waking at different times. So we have to think about our meals, and if we are at high risk of developing diabetes, we need to be careful so we don't get it. And if we do, we have to be careful so we don't get further complications, So our biological clock is important, our hormones like cortisol and melatonin rhythms are important, and of course, further complication avoiding is important. Okay, so I hope you guys are doing all right, and we're following well. But if you have any thoughts or questions, please keep them in the chat, and we will get back to you in the communications. So let's move on with therapies. Now, we talked a little bit about therapies and like insulin, like metformin, but there's a mixture of old and new medications. And the reason that we choose a particular medication over another, or sometimes combine medications, is because each of them has what we call a different MOA, a mechanism of action. So sometimes we only need one drug to help us with this particular issue that we have, or sometimes we need 2 or 3 to help us complete the picture. This one will work here, this one will work here, this one will work here. Now we fix the whole management. So of course, for diabetes, everybody knows insulin, but maybe something that we do want to share or to re-emphasize, if not aware, is different types of insulin. If you remember in the first few slides, we said that naturally in our bodies, insulin, there is background insulin, which here we talk about long-acting or ultra-long-acting insulin. And when we eat that chocolate, if you remember, we want some insulin to come out very quickly, fix this high glucose because of the donut or the chocolate that we ate, to come back to normal. And here we use rapid-acting or short-acting insulin. Why we use both together usually is to make it as physiologically close to our human body reaction to food. So rapid acting, for example, like Lispro, Aspart, or gluten, and I think you would maybe hear some of those if you're familiar. Also, Humulin or Novolin. Now, the long acting, you have things like Glargine or Detamir, Degludec, and sometimes you get intermediate acting like MPH, but they're not often used. It's a combination of these two that we get. Okay, and the doses and the units of insulin that are required are set by the treating physician, consultant, and the MDT team, multidisciplinary team because it will be matching the person's lifestyle, food intake, when do they eat, any other complications, their age, what type of diabetes, how long they've had diabetes. Many things come into choosing the right type of insulin or the combination of insulins for the patient. So adherence is really important, especially in patients with type 1 who do not have any more insulin inside the body. It's not insulin resistance anymore, it's just insulin depletion. Okay? So like we said that there are different types, and these types work in different ways. And I put some images just to kind of give you an idea of where they work. So for example, you've probably heard of something like metformin or glucophage in the brand name, but the actual medication is called metformin. And for type 2 diabetes, it's one of the first line therapies. And how does it work? It works on the liver, okay? It works on the adipose tissue, and it works on the skeletal muscle. And what does it help? It helps the body absorb insulin and improve that insulin resistance, and by improving the insulin sensitivity. Okay, so this is good. It means that if there is lots of glucose in the body, we can reduce hepatic actions like breakdown of glucose because we already have a lot of glucose. We can change some of that glucose into glycogen stores, so we can store it so it's not out in the blood. We can secrete it. And so all of this, by working in the liver and the muscle and the adipose tissue, the whole body is reducing blood glucose. And then we have other groups like the sulfonylureas, glipizide and glibenclamide. You've probably heard of those. Thiazolidinediones like pioglitazone, or rosiglitazone is not really moved much. Also, they help insulin sensitivity. These guys here stimulate insulin secretion because sometimes you need more insulin to come out to help reduce blood glucose. And there are more newer drugs and medications like TPP4 inhibitors or GLP-1 receptor agonists, all your Mounjaros and your Ozempics that work here. And they're primarily for weight loss, but the benefit that we get also is the glycemic control, improvement in glycemic control. SGLT2 inhibitors we'll talk about a little bit later, and they actually lower blood glucose, and the positive thing they do on top of that is reduce cardiovascular risk, and look, they have a good positive renal impact. Insulin, we talked about, essential for type 1 and eventually for type 2 or advanced type 2 diabetes. And I've added herbal or adjunct therapies because we cannot omit that people still use them, but we have to use them very carefully, and they have to be very specific, and you have to tell your treating consultant because sometimes they overlap with these medications and give us the opposite result. So not everything herbal or natural is good in particular combination. Maybe alone it's okay, but together, if you are or somebody on all these medications and taking other herbal things, they have to disclose this to the treating physicians. And so if we just focus on these three main groups, metformin from the biguanides, glibenclamide and glipizide from the sulfonylureas, and things like EMPA and dapagliflozin from the SGLT2s, we can see something like this. Metformin, like we said, works on the liver, glucose absorption, and on the muscle. So it really works throughout the whole body. And this is important because it improves insulin sensitivity. And for type 2 diabetes, it's the first line treatment. And usually it is combined with other medications for better glucose control. So sometimes we start with the dose, then we start with an increase in the dose. And if we reached the maximal dose, then we start adding combination therapy. The safety is that it's really favorably safety. It's been in the market for so many years. Does not cause weight gain, because sometimes insulin can cause weight gain. I mean, it does, but we have to weigh always the benefits with the risk of not using it. This is another issue that we have, and it offers cardiovascular protection, which is really important for patients with type 2 usually, because often there is obesity, and obesity increases our cardiovascular risk. Now, if we think of the sulfonylureas, you can see that, they work again on different tissues, and they increase insulin secretion, like we said, from the pancreatic beta cells that we saw. And, these drugs had the first generation and the third, now they're on the third generation. And what this means is that, researchers and chemists will go and adjust the formula to make the drug even better, with less side effects, more positive effects. So now we are on the third generation, and they are used in non-overweight patients with preserved beta cell function. So there is some beta cell function, but we need more. However, we need to be mindful that there is a risk of hypoglycemia and weight gain. Now, the hypoglycemia is more acute, which means it needs more awareness and reactivity. So, continuous glucose monitoring is important for risk of hypoglycemia. We have to check if the patient has hypoglycemia unawareness, like we said earlier. And for patients with diabetes, we always say, have something in your bag in case you feel a little bit low, if it is a glucose tab or a small juice in the bag, just for sort of emergency situations. And if we look at SGLT2s, like we said, like EMPA and LAPA, they inhibit this transporter in the kidney tubules. So this works inside our kidneys. And this means that we have reduced glucose reabsorption. So the glucose does not stay in the body anymore, and it is excreted in the urine. So this is good for patients who have high blood glucose levels. So they reduce the blood glucose levels and have protective benefits for the heart and kidneys, again, mainly in type 2 diabetes patients. But they have low hypoglycemia risk, which is kind of good, right? We need that, like we said. But possible side effects may include urinary tract infection and dehydration. Why? Because there's going to be a little bit more blood glucose or sugar coming out from the urinary tract, so there might be some infection, but with hygiene, I think that can be reduced. And like with the insulin, the GLP-1 receptor agonists like your Victoza, Byetta, Ozempic, Mounjaro, all of these, okay, they have different types. They are different. They're not all the same, action. They're the same class of drugs, type 1 receptor agonists, but they're different. So, so some are short-acting, long-acting, and some are dual agonists, like we say for the Mounjaro. And they work how? By affecting glucose-dependent insulin secretion, suppressing the glucagon secretion, which works in opposition to insulin, slows gastric emptying. It means the food comes out of your stomach slowly, which is why you feel full for a longer time, and so you don't eat too much and your weight goes down. But the advantage of all of this is that by proxy, or as a let's say as a bonus of coming out of this, is a reduction of HbA1c, and it's been observed by 1 to 1.5%, which is significant. And also there is data to show there is improvement in beta cell function and insulin sensitivity, and so the benefits are overall body benefits, right? Improved glycemic control, weight reduction, cardiovascular protection, anti-inflammatory effects, and renal benefits. However, every drug has risk and benefit, has advantages or positive events and adverse events. So please, even if you feel that you can have Mounjaro from anywhere or any of these medications, please do so only after speaking to your treating consultant, because only they know, and your healthcare team, only they know your history, your current risk, your current medication. So please do not just use anything off the shelf. And Even if both of us have diabetes, the same type, the same year, we are two different people. And so we have to have individualized therapy. I can't use your medication and you can't use mine. Okay, so this is really important. So one of the things that people talk a lot about is lifestyle and well-being, and now we're talking about longevity. But really, what is it about it that we need to think about and keep in mind, you know? Because there's so many things to consider and different ways people have a lifestyle, you know. But if I have diabetes and this other person who has a very different lifestyle to me has diabetes, our goal is the same, to make sure that we maintain glycemic control for as long as we can. Okay, so how do we put all these things together and what is new? What's new is that personalized medicine is really important and been recognized as steadfast for a lot of holistic long life with the quality of life. It's not about living longer anymore till we're 80 or 90 or 100, but it's about living well, about having our body functioning as well as possible. And remember, glucose is everywhere from your brain. Your brain only takes nourishment from glucose. Your eyes, your ears, your teeth and gums, your heart, your extremities, your muscles, digestive system, and all the organs that make us work as humans, all the way to the ends of your toes and fingers, where people can get neuropathy and amputations and gangrene. So really, the blood glucose is circulating all of us the whole time. So what's new? Personalized medicine is important. Biomarker-based therapies is important. Advances in genetic profiling and biomarkers and neuroimaging are actually enabling us to personalize interventions. And this includes things like immunotherapy, gene therapy, neuroprotective agents, you know, for diabetes, islet transplants. You hear a lot about stem cell therapy. Now, is all this happening? Absolutely, yes. Is it all based on scientific research? For the most part, yes. Is it all going to work today? Not necessarily. Okay, so we have to scientifically and clinically judge and profile all of these things that we hear about to make sure if it is something that is going to give me the outcomes that I need, and it is proven, validated by the international scientific community for clinical use or not. If it is, there are usually guidelines that all the clinical world will use. And so it's really important to not just hear anything and feel like you want to apply or experiment on yourself. And so for sure it is happening, it is progressing, but applicability, clinical applicability, please always investigate and run any ideas and thoughts by your clinical team. But it is really important. Why? Because it's affecting family life, it's integrating genetics, it's integrating how we live our life. Things from the environment that affects us, pollution, toxicity, impure water, plastics, and so on. And also medication and how things are changing. Regenerative and integrative therapies. What does this mean? We talked about stem cell therapy, but there are things like, for example, microRNAs or nanocarrier delivery-based systems. And in the UK, we actually had one of my colleagues was working on nanoparticles, delivering the drug inside the nanoparticle, which we then inject to make sure that the drug reaches the area that we need. So this is not science fiction. It is all happening. It is true. We are made of stem cells as humans, and all living beings have the progenitor cell, a source. But how does it help in diabetes specifically? There is still a way to go yet. In wound healing, 100%. In tissue generation, yes, it works. But in diabetes, we have to think about, you know, the gap in the journey. But it's important because, you know, things like this can accelerate recovery, improve quality of life, particularly in older populations. Because like we said, it's not about living to 100, it's about living well to 100. And it's a mixture of things, okay? So, you know, functional medicine, Western medicine, neuropathic, holistic, regenerative, osteopathic. So it's a combination of things, and we have to always balance it as we move forward. physical activity and lifestyle interventions. Now, before we used to say, oh, diet and exercise, okay? Then we added stress management. Then we added restorative sleep, not just sleep, nap, restorative sleep, where your body and hormones recover. Positive social connections, which is mental well-being and community. Minimizing risky substances. We talked about, recreative drugs, alcohol, and smoking. So we are adding more to our lifestyle interventions, but in each one, we are actually going deeper. So for example, before we said, okay, exercise, but what type of exercise? For how long? Is it better in the morning or in the evening? Is it better if I mix it? Can I mix it? What is my vitals when I'm doing this type of exercise or that type of exercise? VO2 max is, my maximum oxygenation. So there are lots of things that we have to think about it in detail, and not create goals that are unrealistic. I can't ask somebody who's working, let's say, a night shift to exercise for an hour every day, 6 days a week. Maybe it's not possible. So it's again, not just the number of things we have to think about, but the details in each one and how it's applicable. Yeah, we don't want something theoretical. Now, neuroticals and herbal medicine, we talked about that earlier. We can't just use everything in any combination at any time with any medication, with any person, with any age. It doesn't work like that, okay? So each of the herbs may have, aspirin came from the tree, the willow bark tree. So we're not saying that medication and nature are very far away, but to get the active ingredient of aspirin from the willow bark tree, to get it purified, to test it, to make sure it is a therapeutic dose, to make sure that it is protective, to make sure where is the toxicity level. These are all very complicated, and it takes 10 to 15 years to get to a drug, and then it takes another 10 to 15 years to test them on populations to make sure that this is a safe drug, it will give us positive effects and not many, and so on. So it's really important to understand that, yes, these natural things can help with aging, reduce inflammation, cardiovascular disease, 100%. But again, there is a specific way to work with complementary and alternative medicine. And one of the last things we're going to talk about is really technology and innovation, right? It would be impossible for all of us to sit together in one forum today and have this great conversation, hopefully soon, in the middle of our day, no matter where we are, without technology. So in terms of diabetes, how is technology helping us? There are two things we were going to talk about, okay? But let's understand first how and why. Everything that we have now that's technology based, like our phones, like any smart devices, is not just based on AI, but based on algorithm driven technology. And the algorithm driven technology means that there is machine learning, okay, and the system is able to learn from the system, from itself. And if it's connected to us like a blood glucose monitor, and we will see, it will learn from us to teach itself to be better. See, so it is actually a little bit complicated. So what we are trying to do is think also about accessibility, right? If I have, let's say, 100 diabetes patients in the clinic, I can't monitor them all the whole time, every day, everywhere, right? I will see them in their review, in the regular follow-ups with me, but perhaps sometimes for certain patients that are high risk or are changing their medication, I need to follow them really very closely. So accessibility, is important. Precision is the second thing. Precision. These devices can tell me at any time, per minute, how much was my blood glucose, how much insulin I had, and we will talk around that. So it's really important because it's a better way than giving somebody medication and say, I'll see you in 1 month. Here I can tell by minute, 1 minute by minute. You ate this is what happened to your blood glucose. You didn't sleep here, this is what happened. Ramadan came, look at your blood glucose. So we can not wait too long to adjust any medication or any titrations that we may need. And this is all evidence-based, and real-world data or real-world studies have shown us that these are reliable. So what are we talking about in diabetes? Well, we're talking about two things mainly, CGM and insulin delivery system. So if we talk about CGM, which is continuous glucose monitoring, because really continuously I can see the glucose level. And there are different devices that can do this. And at the moment we have at ICLDEC and our patient cluster, we have 3 and soon 4 of the really main types. And how do we use them and why do we use them this way? Actually, remember when I said each person is different, even if we all have diabetes, and these devices can actually make sure that this remains the case. So generally, we want everybody to be around 70% of the time. You don't have to be 100%. Great if you can, but at least 70% of the time in normal glucose range. It's okay if sometimes it goes a little bit higher, hyperglycemia, or a little bit lower, hypoglycemia. But like we said, hypoglycemia is if the level goes of the glucose too low, and we can lose consciousness. Like we said, we could be in a car or operating heavy machinery, so it's a bit dangerous, and we try not to do that. Hyperglycemia is not immediate like hypoglycemia, but long term it will give us all the problems that we know, neuropathy, nephropathy, cardiac problems. So each of them are different, so it's better to get more green as possible. But for a person with type 1 and type 2, the green, the 70% is okay. But if it's an older patient or high risk, 50% is okay. If somebody, is pregnant with type 1 diabetes, we need them at 70, but we don't want any orange. No severe hyperglycemia. If somebody in pregnancy, for example, has gestational and type 2 diabetes, we want them most of the time, if not almost all the time, to be in the green. You see? So different patient, different criteria. That's why, like we said, my therapy is not your therapy. Please make sure that your treating consultant is aware of everything. And so this is personalized medicine. And when we get the report, or you in the patient, if you have a CGM monitor, you can track your numbers, you can see your readings. You want, like we said, 70, 50, 180 to 50. This person, for example, green, only 33%. Like we said, we want 70. But what is their problem? They have a lot of orange. So we want this one to be more green. Red, we want to reduce, and you will get something that looks like this. And ideally, what we want is all this blue to be between these green lines, which is what we say your target range. What is the target range? It depends on you. Okay, so all of this is very cleverly put in the devices, and they will help you understand your blood glucose. Now, if we said, remember in type 1, we do not have pancreatic beta cells, we do not have insulin. So these patients have to have insulin. Before we used to inject them, and the insulin pens still exist. However, technology now allows us to have machines that can deliver this insulin to the body in a continuous way. Okay, and we have these 3 currently in our hospital. And I will just show you very quickly this. I don't expect you to read it even or see it, but 3 things that are important for patients with type 1 is the glucose fluctuations. Remember, we said we don't want the blood glucose to go up and down too much. We want it to be as normal in the middle range. Also at night, because we don't eat when we're sleeping, right? And if we did not eat a big dinner, then our blood glucose can really go down. So at night, nocturnal hypoglycemia, blood glucose going down is an issue. So these devices can help us see if we have it. And if it goes too much, it can adjust the insulin so the patient does not have this issue when they wake up through the night. And HbA1c, we all know HbA1c, it's a measure of our cumulative glucose in the body every 3 months, because that's when the red blood cells renew. And no matter if you have this device, this device, this device, this device, or this device, the important thing is your HbA1c, like here, your hypo at night, especially at night here, and your time in range, the green here, the fluctuations, these are required to be good the whole time. Okay, so don't worry too much about what device. Your treating physician will consult with you, but this is the important thing. And again, it's very complicated. The machines are very smart and they can track you. They will say, oh, when you started before, you were 59%. Then let's say you come to us and we have the conversation, or your treating physician, and then you sit with the diabetes educated dietitian to see how the food is affecting. Then you come back and it's 74%. Okay, we're doing good. What else can we do to make it 80, to make it 90, to make it 100? Yeah. And here are all the technicalities. You saw the machines earlier. You can adjust so many things. Okay, how much insulin, how long, and meals, your carbohydrates, everything. So it's very smart. And what the machine does, the algorithm gets smarter. It learns from you. You know, you eat at this time, you eat this much at this time. Maybe I will reduce the insulin a little bit. Maybe I will increase the insulin a little bit. So your consultant and your diabetes educator and your dietitian will adjust the settings with you, will monitor with you. And this is important for safety. Like we said, we don't want hypoglycemia and lose consciousness, or hyperglycemia and all the complications in the body. So I think with this, I want to thank you for your time and attention. I hope that we have gone through a journey of, the biology and the lifestyle and the way to the technology. And I'm here for you for any questions that you may have. Thank you.
Thank you, Dr. Tomader, for the informative presentation around diabetes. We will be moving now to the Q&A session. Our first question is regarding HbA1c and blood issues. So, for HbA1c test result, would it be accurate for people who have blood issues such as anemia?
That is a very smart question, and generally no. So we have other biomarkers that we can use. We do frequent tests, and we also have continuous glucose monitoring. So yes, that is a very good question. It is a factor, yes.
And thanks, doctor. The next question that we have says, in case of traveling, how can I preserve insulin?
That's again a fantastic question, and we do have a quarterly education awareness session. I'm happy to share details, but we have a whole module on travel. So insulin, in terms of temperature, ideally stored in a cool bag, 2 to 8 degrees, and most airlines, in fact, almost all airlines, are happy to assist you with that during the flight time. Often, you can get a letter from your health facility or your treating consultant and their team to accompany that, to help you through your journey, especially if it is a long journey, or if there are extremes in the temperatures. For those who have, usually also the other side of it is the injection and the needles and carrying that, or the pens if you are on MDIs. Also, the health care facility can help with letters to help you through traveling. If you are on devices, whether they're CGMs or insulin pumps, ideally not to go through, some of the machines, not to put them through the infrareds because they can affect the algorithm a little. So it's better if you go through the manual search, and if you have your medical note with you or your travel letter, that often helps a lot. So yes, temperature is very important for sure.
Thank you, doctor, for answering that. Also, a member of the audience asks, certain injections decrease my appetite and I'm afraid of hypoglycemia. What can I do in this case?
Fantastic. So it's a combination of things. Now, if you awareness is important, so that means that your body is still able to respond to feeling that you have low blood glucose, which is good. If you have a continuous glucose monitoring sensor, that will be ideal. Little and often, eating little and often is still important, so maybe be mindful of that. And have something, like we said earlier, in your bag, just in case, so like either a glucose tab or a small juice or a date or something like that, and to help.
And doctor, moving to the topic of diet. So what are your thoughts about intermittent fasting and at the same time also the keto diet for diabetic patients?
I mean, so this was it's such a big conversation, but the general thing is there is no specific diet for diabetes, you know, because type 1 and type 2 have very different etiologies and pathophysiologies. Often patients with type 1 are more slimmer built. Patients with type 2 often carry a bit more weight. And so, you know, the different types of, let's say, eating styles are going to, you know, to affect their blood glucose control. And the idea really is to develop good eating habits, you know, that not just match in quality, but match in the lifestyle. So I could be a slim patient with type 1, but I have a very active lifestyle. So I'm going to have to increase my calories to match that, but they have to be very good calories, you know. If I am an overweight person with diabetes, type 2 diabetes, and I want to kind of reduce that weight, it's yes, quality, but I'm gonna have to think about my calories more, you know? So it really is a combination. And the other thing often with dieting as a principle, as opposed to changing the way you eat long term, is that it's not maintainable long term. Even if people do it for a small amount of time, it's often difficult for them to keep it for life because, you know, any good habit should be for life, really. You know, so with diabetes, for sure, you want to keep it maintainable.
And doctor, in Ramadan, so for people who have diabetes and they are fasting, so better to exercise before or after iftar?
Such a good question. So many good questions today. Okay, well, remind me of all the parts of this because there are so many. So first of all, Ramadan fasting, we have to seek medical advice before to ensure that it is safe fasting. And usually for our patients, we start pre-Ramadan education 3 months before Ramadan because some of the medications and the hormones need 2 to 3 months to adjust, okay, the medication, because we can't just change the medication the day before Ramadan. That's too much for the body. So secondly, during Ramadan, you know, some people's life does not change during Ramadan in terms of lifestyle. They still do a 9 to 5 work, you know, or some people do a complete night shift. So how do they eat? And when they change the medication administration, because you're fasting during the day, now your medication is going to be in the evening. So, you know, and some medication require absorption time. So, you know, for thyroid, you need to wait half an hour. So imagine fasting, you break your fast, you take your medication, you wait for half an hour, then you take your so sometimes adherence is difficult. So if you add exercise on top of that, you know, you have to be super careful. Type 1, type 2, oral medication, injectables. What kind of exercise? Is it a gentle walk after? Is it a walk after food, or is it vigorous exercise after Taraweeh? You know, so it really, to the extent that the International Diabetes Federation (IDF) have a Ramadan guideline, you know, diabetes and Ramadan guideline. And we have contributed to the 2021, you know, series, and it has a lot of information, gets updated regularly. The conference is coming up soon. So it's really important for you to personalize. We talked about personalized medicine. Now, if it is calorie-based as a general now, okay, ensuring that safety is always the main top priority. Generally, for weight loss, some people do something called fasted cardio. So, you know, before breaking the fast for half an hour to 45 minutes, they would do some, let's say, on the treadmill or the cross trainer for some time. But if somebody is fasting who has diabetes and is, let's say, recommended to not fast, but they're fasting anyway, which happens and it's fine. It's fine, as in, like, it's a reality. It's real world data. It's not. Then these patients have to be very careful, you know. So we can't say please do that. But if they want to exercise after they've eaten, they've broken their fast, after they have taken their medication, after they check their blood glucose, okay, and they're okay to exercise, then they can do so safely. One more thing to think about is that depending on the type of exercise, aerobic or anaerobic, the target blood glucose, we call this a temporary target if you run a medical device, for example, can be changed so that your insulin is not just giving out insulin, you know, or stopped because you're going to get a high anyway from your muscles. The glucose is going to come out of your muscles when you're exercising. But it's not hyperglycemia because your diabetes is bad, is because you're exercising. So we will adjust that temporary target, but it will go back after exercise. So it's very delicate, you know, it's very specific. So all of these things need to be considered. And the important thing is we want exercise to be safe and healthy. So let's make it in a safe way so it doesn't give us the opposite effect.
Thank you, doctor, for the detailed explanation. Now we will have our last question. What to do if someone faints because of their low blood sugar levels?
Very, very good. So glucagon usually, glucagon pen, it looks like an insulin pen, and it will help to counteract the insulin. Secondly, you know, I mean, first of all, urgent medical attention, 91999. If you're not in a healthcare facility, check the blood glucose sugar because you want to make sure that you're not making things worse, you know. So check the blood glucose sugar, call the emergency, recovery position. If they are too low, this is when you can give a juice or a glucose tab. If it is too high, because it happens, people can faint from DKA, that is a medical emergency and requires hospitalization because they will treat as emergency care and ambulance delivery 100%, yes, because they would infuse and titrate insulin until you reach euglycemia again.
Thank you, doctor. So with that, we will wrap up the Q&A session. Thank you once again, Dr. Tomader, for sharing your expertise and valuable insight on such important topic.
A pleasure. Thank you very much. It's a fantastic forum, and I hope everybody had, maybe some queries answered, and thank them also for their attendance and their willingness to spend the time learning about diabetes. It's a great public health responsibility, and everybody should be very proud of themselves. Thank you very much for the opportunity.
Thank you, Doctor. And to our audience, we have now reached the end of our webinar. Thank you for joining us and participating. Please take a moment to answer the survey questions. Your feedback and input are appreciated. Thank you for joining us, and we will look forward to seeing you all again in our upcoming webinars.
Very much. Have a great day.